We will continue with the next speaker, which is Inger Lindberg. Now, Inger is associate professor at the Luleå University of Technology, so she's almost on, this is almost her home field, isn't it? Yes, and Inger will be talking about renewing health, the new methods to enhance and preserve health.
Thank you for having the opportunity to present the results from Renewing Health that we have been working with for so long time, I think it has been. No, sorry, I did something wrong. Push the wrong button.
Yep.
Okay, thank you. So I'm going to present some results from the Renewing Health project in Norrbotten. In Norrbotten we had 739 participants, and they came from 4 healthcare centers. And it was also, as Pano said, it was a randomized controlled trial. The aim was to see if the application or the intervention could improve quality of life, health and self-management in persons with type 2 diabetes, CVD and high blood pressure. The application we used is called Prescribed Healthcare, and it's an application to the National Patient Portal that's launched in Sweden. In this application, patients get treatment instruction through video messenger or other description from their healthcare staff or the diabetic nurse or their GPs. They can make their own preventive healthcare and medical diagnosis measurements. And they also can have medication information, alarms and follow-ups, and do some video consultations. The equipment they used were step meters, blood pressure, glucose meters, pulse watch, ICGs and QuagiCheck. And the participants that don't have their own PC, they got an iPad to use from the pilot, from the project. The application, as I said, was an application to the National Patient Portal. It has a secure authentication with a patient eID or one-time SMS. And the staff, they used their SITS card, that they had a smart card they had in their employment. It's based on open source, and it's with the intention that all healthcare providers could offer the application to other to patients, but also to other organizations further on. And it's an open architecture for scalability and flexibility. The picture on the right is one of the views that the patient have when they have registered their measurements. So the application is that the patient, or the method and the application is that the patient make their own measurements for blood pressure or blood glucose and so on, that they had from the GPs or the diabetes nurse, and then they register their values in the application and get the view of how their blood pressure or the diabetes, the blood glucose varies in relation to physical activity, or if they have done some other lifestyle changes. When the patient had registered their values, the nurse or the GP can go through them and then perhaps respond on and give them some new ordination to perhaps change their insulin or something like that. As Pano said, we have used MAST as an evaluation method in the project. And in Norrbotten, and I think it was in all regions in the Renewing Health, the primary outcome was SF36. And for those with patient with diabetes, HbA1c was also a primary outcome. Secondary outcome in Norrbotten was also blood pressure, serum lipids, use of alcohol and tobacco, activity habits, HUDs, patient and healthcare staff's perspective, economical evaluation, organizational aspects. So it covers a broad aspects of projects, broad aspects in projects. This is a little about to tell what kind of participants we had in Norrbotten. This is for the whole group. All diagnoses. So it was quite similar in the intervention control group, and I will be back to why there is a little bit difference between the groups. The age was about 65, 67, mean age. There were slightly more men in the intervention group and more men than women. There were few smokers using tobacco. They were quite active in using physical activities, as you can see. And the use of alcohol was also quite moderate. They were used to use PCs or mobile phone. And this says something about the persons that participate in the study, and perhaps why we have the results that we have. Here are they divided according to the diagnosis. From the beginning, we had two diagnoses that was type 2 diabetes and the ischemic heart disease. But according to a review from the EU Commission, we have to separate the CVDs and the hypertension, and then we got three groups. And this was done after that we had done the randomization, and that's why we have a little bit different number of participants in the groups. The mean age is more or less the same in all the diagnoses. And, but we can see here there's some more men here in the CVD groups, and that is it's a result of or it's more common to men to have CVDs. It's the same about smoking, and they are quite active in physical activities and not using alcohol, and the penetration of PCs and mobile phone is quite high. So that perhaps is why we have the findings that we have. The results on SF36 is showing that there have been no difference in improvement between the intervention and control groups according to diabetes and hypertension. The only significant statistical significance was in the competent physical function in patients with CVDs. And by that I mean that the participants we had in the study, they were quite used to using PCs, mobile phone. They were quite active in physical activities. They were quite interested in their health already. That's why one of my explanation for the results. In the study, we also used a questionnaire that studied the patient's accessibility of the technology. And we did that in the end of the project. And this is an ordinal scale, and it's from 1 to 6. And it's not so easy to understand it, but I will. It was the questionnaire in whole, I think it was 24 questions, but here are the subscales from these 24 questions. I have a problem with this. This means that the patients, the participants, were quite happy with the application and thought that it was enhancing their care. They also thought that the application increased the accessibility to healthcare and it made them to have control over their own health. They were not so concerned about privacy and discomfort, to have no special thoughts about that. And they had no special concerns about the staff's, the healthcare professionals' competence or continuity of care. According to KIT as a substitution, there were more hesitating if this application could be a substitution for meeting in person with the healthcare staff. But overall, they were very satisfied with the application. We did also some qualitative studies with the patient and the healthcare staff. And we did 34 individual interviews with the patients, and it was 34 with all 3 diagnoses. And the patient, this is more like meat on the bones on the questionnaire. The patient thought, it was the equipment, the application was easy to use. It worked well. They had no problem. Some of them had problem with the ID, but when they solved that problem, it was easy to use and it worked well. It was easy to make the measurements and so on. It worked well for elderly and for those who are not so skilled with computers. We had 10% of the participants didn't had computers, so they got an iPad, and half of them could learn to use an iPad, and half of them could not, and withdraw from the study. And they mean that it's not need to be personal meetings all the time. It could be meetings like this also using the application, sending emails or have video consultations. But what they strongly stressed on was that they needed feedback. When they have registered their values, their measurements, some of them had no feedback from the GP or from the nurse and said it was like sending their values in a black hole. So they strongly stressed the need to have some feedback from on the values that they had registered and sent in. They also thought that this application improved their self-management. In this way, when they made their own measurements, they could relate their measurements and follow on a time period. They could also see the relation to physical activity if for example, the blood pressure had improved. And this was very positive. As I said before, privacy and integrity was no big issue for them. And they thought that this is something for the future, and they think they are in the future, and this is the way the healthcare is going to be in some way. There are some quotes from the interviews. We had focus groups with healthcare staffs and had 4 focus groups on the healthcare centers. And the participating professions were biomedical analyst, diabetes nurse, district nurse, occupational therapist, physician, physiotherapist, medical secretary, and enrolled nurses. The healthcare staff also thought it was a very good application, it was a good method, but they were not prepared to change their way of working, they changed the way to organize the care. And they say they also said themselves that they also have a certain resistance to make something new. They meant that this method and this application strengthened the self-care, the self-management for the patient. But they meant that this is something for the patient. It's nothing for the healthcare staff to deal with. This is something for the patient to deal with. But they also had the opinion that the application and the technology worked well. They had no problem with it. So the conclusion, patients are satisfied with the service, with the application and the method. They felt that they improved their self-management. They felt empowered. Healthcare staff also thought that the application and the method improves a patient's ability to improve their health, but they thought it was something for the patient. So there's a paradox. Patients thought it worked well, but they wanted feedback from the healthcare staff. The healthcare staff thinks this is something for the patient to manage for themselves. So there are different expectations for the services. The power of this kind of treatment method will probably be higher if staff is dedicated to preventive work, because what we saw that was this service was only added to the ordinary work. It was nothing that was changed, or so it was only added to the ordinary care. And today's compensation system do not provide a reimbursement for remote consultation, and this is very important. They need some incitament to do this kind of work. Thank you.
Is there anyone in the audience who has any question for Inger? No? Okay. Well, yes.
Can the county decide autonomously to reimburse teleconsultation and telemonitoring? It has to be a decision at national level in Sweden.
Well, I don't think I'm the person to answer this, but I know it is a national issue at the moment. PU, I think you can answer it better than I can do.
Turning the spot.
I know that they are discussing this
Yeah.
on the national level, but
Yeah.
of course I think as we are responsible for the healthcare in the county council, we can do as we want. And we are working with a strategy right now, because this is some of the things that is hindering us from going further to solve this actually. But it's not so easy actually to do this, but we need to do it in order to get forward.
Okay. I was only wondering, the conflict, the patient wanted feedback, and it was very important for them. And the caregiver didn't find that quite so important. There is a conflict there. Do you find any, or do you see any solution on that conflict?
I think that you have, in one way, you have to decide what is the patient's interest or responsibility to make their own measurements, and when is the patient ill, and when is the contact needed with the healthcare organization. I don't have the answer on that, but I think there is a conflict, and it's a conflict on expectation, and you need to be very clear what you are promising for the patient.
It's a kind of a different one for reflection, but I was thinking when you talked about the patients, I don't think that there could be a time when you ask people in advance if technology is a good solution to not having access to their doctor, that they're going to say, yes, I'd rather do that. And at least as I've understood, once they have access to the technology, it becomes a substitute as long as it's not seen as a barrier to seeing their physician. And when I saw your data, I had wondered if people would say, if you ask me, if you do this, then it'll mean you don't have to see your doctor. It seems to me that people would say, but I still want access. So it's additive rather than a substitute, but then over time it does substitute, at least as I've been understanding the research.
I agree with you. I see it that way. We are not, I think we are not there, and we still have people who need to have access to nurses and doctors, although we have a lot of technology and this kind of services. But we need, my personal opinion is that we need both. But I think there are a lot of people who can handle their health if we trust them in this way as well.
Can I take it on? The conflict of interest between the caregivers as they are working in a traditional environment and also participate in this new tradition. How do you solve that problem? Because time is time, and when we are trying to give something else, as you say very, very clearly, it is not a substitute. It is additive.
Yeah, it is additive.
And therefore, since we don't know how long will it take before we can see that this doesn't give us a negative outcome to the patients that are not included in the study, or do you understand what I'm aiming at? My point.
Somehow, yes. I think it's further studies is needed, and yes, the service was added to the ordinary care organization. And the staff said that we don't change the organization until we have a decision. Until that, we don't change anything. But we need a decision, then perhaps we change, but not before.
So, this is so fun for me, but in our system, which you'll hear a little bit about tomorrow, but it took about 2 years. And the average number of primary care visits went down a full visit after about 2 years, where they had access to email their doctor, to do telephone visits. But the trick was we couldn't put email as do this rather than have access, because that would not play well to the patient. It just starts to happen. Because the email was not a tidal wave. The patients were very careful with when they would send emails, but it took about 2 years, and we saw an annual number of a visit per patient per year go down across primary care.
Okay. Think we can just do one more? Yeah? Don't want to stand in between people and coffee, so...
In Sweden, it's very dangerous to stand between people and coffee.
Exactly.
Or get run over. Unless it's by a train, then you won't get run over because they don't come at the moment. I think we're comparing apples and oranges when you're comparing the US system and the Swedish system. You said if you're starting from a starting point of access to care, the people won't choose it. We're not starting from that starting point. We have the worst access to care in Europe, just about, with regards to what we call tillgänglighet, or how fast people have access to care here. So I think that they've got a completely different starting point from what you've got in the US. I had a reflection on two of the conflicts. One, the conflict for healthcare professionals, that we think it's a conflict to do things for patients. It's a bit worrying for us as healthcare professionals. And if we keep thinking that way, we're not going to have time to do all these other studies, because the morning session said that the patients are pushing these things. We can have beautiful studies, randomized controlled trials, thousands and thousands of patients, and the patients are going to do things that they want to anyway, and we're not going to have the time to... they said that no, they're not too worried about how they're... what sort of randomized controlled trials they're doing on their apps, or what sort of results they're getting. They're just pushing forward anyway. So we can sit there and think that we're not going to do anything for our patients before we get paid for it, and they're going to drive over us. We hope in Sweden that that's with a train, at least in Norrbotten, because then we know that it won't come.
I think that's any follow-up to that, or should we end it on that? No?
I agree with you. I think the patients or the participants or the citizens, they are pressing on to have this kind of services, because they're used to many other things that they can do on the internet or emailing or so on. So I think they are doing the pressure.
Good. Okay, thank you, Inger, from the organizer of the conference.
Yes,
There's a little
thank
time for you.
Thank you.
Thank you.